right, I see our last panelist there, so I think we're ready to go. Thank you everyone for joining us. My name is Nirav Shah. I'm pulmonary critical care at the University of Maryland, and I'm really excited about our session tonight. So tonight we have our ATS COVID-19 Critical Care Training Forum, which is every Tuesday from 8 p.m. to 9 p.m. Eastern Standard Time. Tonight we're going to be talking about cardiac issues with COVID-19, acute and long-term implications. As I mentioned, my name is Nirav Shah. I'm at the University of Maryland. We're going to start with a case presentation by Dr. Karan Desai, one of our cardiology fellows at the University of Maryland School of Medicine. We'll then move into a discussion about COVID-19 and the decision for left heart catheterization by Dr. Anuj Gupta, Associate Professor of Medicine and Director of Cardiac Catheterization Lab at the University of Maryland. And then COVID-19 and Mechanical Cardiac Support by Dr. Sammy Zakaria, Associate Professor of Medicine, Assistant Director of the Johns Hopkins Bayview Medical Campus, CCU, and the Associate Program Director for the Internal Medicine Residency Program at Johns Hopkins Bayview. We'll conclude with Dr. Karan Desai then talking more about some of the acute and long-term implications of COVID-19 and the cardiac issues around it. We have additional sessions that are coming up and then some that have been recorded. So the ones that are recorded and available for free on the ATS website are listed here on your slide. And there are 15 episodes so far that are all posted on this website, and here's the link for that on the screen. Upcoming ATS COVID CCTF or COVID CCTF topics include obstetrics and COVID, and then the whole list that you can see here. Some really exciting topics led by people from all over the country. So please tune into those on Tuesdays at 8 p.m. Eastern Standard Time. And then here is the QR code. Please give us feedback about today's forum and include topics of interest for upcoming episodes. The link is there as well for SurveyMonkey, but if you just point your camera at this QR code, you'll go straight to Safari and to the survey to give us feedback. And with that, I would like to thank the CCCTF chairs, Dr. Laura Crotty-Alexander, Dr. Sushma Cribbs, Bren Call, and myself, and then our team of trainees from UCSD, including Alex Sipro, Cameron McGuire, Ali Ashgar, Neil Jones, and Mark Rolfson, and our ATS staff, who we couldn't do this without, Lauren Lynch, Liz Guzman, Eileen Larson, and Rebecca Fish. Thank you all very much. And with that, I'm going to stop sharing my screen, and Dr. Desai will start sharing his. If you have questions, please put them in the chat box, and we will be answering those in real time and then also curating them for our speakers today. With that, Dr. Desai.
Thank you, Nirav and or Dr. Shah. Is everyone able to see my screen okay?
Yes.
Projecting, okay. So again, I want to thank Nirav for the opportunity here, and then also Dr. Gupta and Dr. Zakaria for joining us, both who I know quite well, one as my former program director, and the other is my current program director in the cath lab. So I'm going to get started. The case here is actually courtesy of the Cleveland Clinic from Travis Howard and Zach Elgovine, who are both cardiology fellows at the Cleveland Clinic. And as a short plug, I work on a podcast called the Cardio Nerds Podcast. This is a case that we just recently presented on there, and this is from these fellows here. So I'll present it, and the context is this is in late April. So this is a gentleman, he's 40 years old. He's a past history with a GSW. He's currently incarcerated, and he's coming into the hospital, initially another hospital, with 1 week of fever, myalgias, and shortness of breath. He arrived at the other hospital with sinus tachycardia. He was hypotensive with MAPS in the 60 range. This was on norepinephrine. He was lethargic. Initially seemed he was having labored respiratory effort. He, in terms of pertinent context for him, he's previously was otherwise healthy. He's been running about 5 miles a day. There's currently not on any medications. And when he arrived at the other hospital, he was afebrile. Blood pressure was 102/80, narrow pulse pressure on norepinephrine. Heart rates was in the 110s, and he was 97% on room air. He looked ill. He had labored breathing. He had prominent sternocleidomastoid mastoid muscle use. His lungs didn't demonstrate any adventitious sounds. His JVD at 90 degrees was 5 centimeters above the clavicle with a sustained hepatojugular reflex. He was tachycardic. There was no gallop. There was a whole systolic murmur, both at the left lower sternal border and at the apex. And his extremities were cool with pitting edema. In terms of his labs, and I'm not going to go through it all here, but you can see that he had a profound hyperinflammatory response. His white count was in the 30,000 range with neutrophilia and lymphopenia. His K had gone to 5.7, his creatinine 3.2. Again, we don't have any recent labs. Presumably this was all acute. AST, ALT were in the thousands. His initial troponin I was 0.4. NT-proBNP was greater than 70,000. Lactate was 9. A central venous O2 saturation off his triple luminose place at the outside hospital was 30%. Ferritin was greater than 40,000. Fibrinogen in the 750 range and CRP at 32. And he was found to be COVID positive and then transferred to the Cleveland Clinic. When he arrived, this was his initial EKG, acutely looking for a patient with troponin, this hyperinflammatory response, you know, as we've all been accustomed to now, looking for myocardial injury, specifically potentially signs of myocarditis or signs that he's having acute myocardial infarction. Don't see it on this EKG. He does have evidence of a right bundle branch and borderline that he's developing left anterior fascicular block, but not a clear criteria there. He does have left axis deviation. And just making a point that when you have a patient with a right bundle branch block here, potentially left anterior fascicular block that may be new, it is always concerning to think about the patient may have an acute occlusion of the LAD prior to the first septal perforator. This was not the case, at least on this EKG here. This is chest x-ray here, and I'll play his CT chest as it loads here. Was striking largely in the regards to the pulmonary findings being not that significant compared to his cardiac and hyperinflammatory state. Looking through his chest x-ray here, you know, this is now about a week, 10 days into his presentation, not demonstrating the findings of consolidation or airspace disease. And again, on the CT chest, we're not seeing you know, bilateral ground glass opacities or the crazy paving pattern and so forth. So moving to his echo, one of the images here, it's cutting in and out here, but when looking for myocardial injury and specifically for myocarditis, one of the crude markers, especially for acute myocarditis, is that we don't expect significant LV dilation. And this patient did have some level of LV dilation and RV dilation. I'll go on the next slide here, which suggests that at least potentially that there may be a subacute course here. And again, we see that he, at least on these images here, that he has relatively profound RV and LV dilation, along with significant MR and TR, mitral regurgitation, tricuspid regurgitation. Again, in acute fulminant myocarditis, typically you don't see that acute LV dilation, and more so LV wall thickness.
I love that the cardiologist just glosses over the CT scan of the chest and spends so much time on the echo with it. And Dr. Desai, I have to give you a hard time, right? Because I'm a pulmonologist, but definitely not a normal CT chest either when we looked at that, right? So definitely some peripheral ground glass that you could see, and even on the resolution that we see on the screen here, it's not completely normal. So I think that I agree with you. It's not striking, no consolidation, but I couldn't pass it up to at least comment on a CT scan that's shown on the screen.
This is a common occurrence when I consult in the MICU.
All right, very good.
And then, so this patient eventually did have a endomyocardial biopsy results shown here. And it did show that he had the COVID virion in the myocardium, specifically in the myocytes, along with in close proximity to the mitochondria. One of the few cases across the country where this has actually been demonstrated. In terms of his course, we don't have initial right heart cath numbers. Through his course, he was not intubated. Given the profound nature of his lactate rise and cardiogenic shock, he was placed on VA ECMO. He did have a femoral impella and then eventually transitioned to an axillary impella. At that time, he was given prednisone, IVIG, and tocilizumab, and he was rapidly weaned off ECMO and had a dramatic response with the anti-inflammatory therapies and decannulated in 3 to 4 days. He's had full recovery. have not talked to the Cleveland Clinic fellows whether he's had follow-up since his acute course. So I use this case to highlight what's been a lot in the literature as well as in our experiences about COVID-19 and myocardial injury. Now, specifically, we think of these as ischemic and non-ischemic etiologies. And knowing from data from the influenza and the flu epidemic, we know that viruses in and itself can lead to acute plaque rupture and acute myocardial infarction. Of course, we know that there is the demand ischemia and supply and demand mismatch, which can be an ischemic etiology, but also a lot of what we've seen as whether it's myocarditis through direct virion injury or a bystander effect on the heart, whether it be from the profound inflammation occurring in the lungs or systemically or iatrogenically injury to the heart because of the therapies we give. And I think this nature diagram demonstrates it here well. But one of the breakpoints, especially for I bet many of you managing patients in your units and across the country and across the globe, is when these patients show with myocardial injury, when do we actually consider taking them for left heart catheterization? And it may not have been as much of a prominent consideration in this patient's case, but certainly a consideration across the board in many of the patients we see. So with that, Nirav, I will send it your way to begin a discussion with Dr. Gupta.
Yeah, so Dr. Gupta, as I mentioned earlier, is the director of our cardiac catheterization lab, former Maryland ACC governor and a close colleague and friend. We've shared patients at, this patient is from Cleveland Clinic, but Dr. Gupta and I have shared similar conversations over the phone talking about patients that we've sent to the cath lab from our MICU. So I think that this is a really important conversation and would love to get your input on some of these points, Anuj.
We're such close friends that I used a picture like that's 14 years old to make me look good. Karan, can you go to the next slide? For an interventional cardiologist, the world became far more complicated in March of 2020. Before then, a patient had ST elevations, and just about every time we would cath that person. And in March, we stopped as a group, both within our medical center and system, and across the country and said, listen, as patients come into the hospital with COVID-19 disease and present with ST or non-ST elevation MI, how do we decide which patients should come to the cath lab and which shouldn't? And importantly, how do we protect the staff who are going to be doing these procedures with us? Because if we infect all of our RTs and our nurses and our physicians because of carelessness, we won't have cath labs to take care of other patients as well. And so in the first weeks of the pandemic, as it came to the United States, we actually had lots of conversations with our colleagues in China and in Italy. And in fact, the American College of Cardiology held training sessions from interventional cardiologists in Wuhan, China, and some of our friends in northern Italy, in Bergamo, that were getting slammed with this infection were giving us tremendous amounts of advice about how to manage the situation. So one of the first things we did was we actually cordoned off one of our cath labs and made it a relative negative pressure room. And the next thing we did was we worked with our emergency room to tell them to change the normal flow of how we would bring patients to the cath lab. In February of 2020, it was easy. The ambulance would call ahead of time with a ST elevation MI. We wouldn't know anything else about the patient except the fact that there was ST elevations. Our entire team was mobilized, and the patient would sometimes even be in the cath lab room before everyone was there. And in March, we changed that flow so that our team would be there, get donned with protective equipment, the negative pressure room would be turned on, and then we would call for the patient. And this only worked with regulatory help too. And so the state of Maryland, regulatory agencies, because of the pandemic and the state of emergency, agreed to suspend not the monitoring of door to balloon times, but the grading of door to balloon times for cath lab. Yeah. There were also efforts to figure out and to manage all patients that were coming to the cath lab emergently as potentially infected patients. And so all of our staff were trained on how to use either PAPRs or wear N95s. They were fitted. And we also discussed extensively what we would do if A, there were not enough cath lab staff available anymore because they were infected, or if a patient came in truly in shock or quite sick with known COVID infection with ST elevations, whether we would consider giving them fibrinolytics. And so I've been cathing now for about 17 years. I've never given thrombolysis for coronary disease. I've given it for pulmonary embolus. And so we actually had to go back with our pharmacists and go over the protocols and get the right drugs available within our pharmacy so that we actually had thrombolytics available if we decided that it was the correct patient. Now, as it's turned out, we've not used thrombolytics to date, and we've been comfortable bringing all patients to the cath lab. Nirav mentioned a patient that we shared who was known COVID positive, incredibly ill, and developed ST elevations inferiorly, who we brought to the cath lab with all of this protective equipment in place. And so as you see, we at the University of Maryland came up with this incredible flow diagram in terms of how to address and take care of patients. And yet in the end, because of our comfort level in how we prepared ourselves and our colleagues that were absolutely critical to doing procedures, we were comfortable bringing these patients to the lab, into that isolated cath lab, which was created as a negative pressure room, and decided that we would treat everyone the same. As an aside, this is an old slide looking at fibrinolysis versus primary PCI. I think if you ask any interventional cardiologist, they're going to say that they would strongly prefer getting a cath if they were having an ST elevation MI than thrombolysis. And it's not just a function of the original trials, which showed a reduction in hemorrhagic stroke, but no difference in mortality. As you look at these meta-analyses with much larger numbers of patients, you can see there's a substantial reduction in both short and long-term mortality, reductions in reinfarction, and just the flow in the coronaries is substantially better with primary PCI than there is with thrombolytics. And so truly, if interventional cardiologists were discussing the possible need or use of thrombolytics, you can imagine how concerned we were about how we would proceed. Karan, the next. This is an interesting paper that was published in Kaiser, and Kaiser has this ability to...
I'll do that. I'll take one.
Kaiser has the ability to do these large-scale studies because of their enormous database, and they saw a dramatic reduction in acute myocardial infarctions, and they published this. And this is very similar to the experiences that we've had in Maryland, in New York, in Bergamo, Italy, when we talk to our colleagues. This is not unusual. And it's not that we think that the patients having myocardial infarctions went away. We think that patients who were having myocardial infarctions decided to stay home and not come in despite their infarctions. And there clearly seems to be a later presentation in these patients. This is a paper that was published looking at STEMIs that presented to hospitals. And you could see that as we went further into the COVID period, patients were presenting later and their risk-adjusted mortality was higher. And it's almost certainly because patients were presenting later than they would have otherwise. Even now, anecdotally, I feel that patients are presenting much later than they had been pre-COVID pandemic. I think that we'll know this much better in the next year or two when we look back at our ACC registries and look at what happened in terms of not just door-to-balloon times, because they were delayed as physicians and nurses and RTs and RCISs got fully gowned before a patient would enter the room, and so door-to-balloon times were delayed, but also patients coming in much later in their presentation. And so I think we'll have a better understanding of how much we've been hurt by the COVID pandemic, even outside the function of infected patients. Next. So I'm going to turn it over to Sammy. Karan?
Hey, Karan.
Yeah, just before we move on to Dr. Zakaria, I think we have a little bit of time here. I don't know, Nirav, if you had any questions for Anuj here before we go forward.
Yeah, I think that the tough part has been, Anuj, kind of, like you said, weighing this idea of do you take this patient or any of these patients to the cath lab or not, right? And kind of what the downside and the upside are of doing this. And I think that from a critical care provider, at times it's really hard to separate kind of where are we seeing someone who could definitely be having, these diseases are just not kind of, if you have one, you don't have the other, right? And we're seeing a lot of data that people like to say, well, this isn't COVID. This is all the heart. It would have happened anyway, right? Are we seeing kind of an increase in the amount of not just kind of going to the cath lab for an EKG that might look like myocarditis or might look like an ST elevation MI, but also with the clotting disorders that we're seeing, are we seeing more clots that are forming that are causing ST elevation MIs? Have you noticed any of that?
On a personal level, I've not. Alok Finn is one of my partners. He also runs CV Path, and so I'm going to steal some of his thunder. He's published some papers now on autopsy results of patients from Bergamo. One of them published in Circ. They had a 40-year-old woman who passed away from COVID-19 disease. And when they did their autopsy, they found no viral inclusions within the myocardium, but they found a tremendous amount of microclots throughout the myocardial bed. And so I think that this is, at least from the heart's perspective, because again, the heart's not the primary organ that's damaged in this disease. But when it does affect the heart, it can affect the heart in a variety of different ways. You saw in the biopsy that Karan presented that they found viral inclusions and evidence of inflammatory cells, and yet we've also got patients who pass away from a primary cardiac death with COVID-19 infection, incredibly sick with COVID-19. And in her autopsy, we found no evidence of viral inclusions within the myocardium. So I think it's a very variable presentation when it does come to the heart. Again, not the primary organ affected, but a very variable presentation in the heart.
Great.
So as we go back to the patient here, we'll remember that this patient was placed on VA ECMO. And I'll turn it over to Dr. Shah to introduce Dr. Zakaria.
Absolutely. So it gives me great pleasure to introduce another friend and colleague, Dr. Sammy Zakaria. Dr. Zakaria is at Johns Hopkins. He's an associate professor of medicine, as I said, the assistant director of the CCU there, and the associate program director of the internal medicine residency program at Bayview. And what you all may not know is that Dr. Zakaria and I also are members of an elite book club where we discuss very, very non-medical topics. And so it's really a true honor to have Sammy here on this call tonight. Thanks, Sammy.
Oh, my pleasure. Thanks for having me. This is a fascinating case, and thanks to you, Karan, and Anuj for your thoughts on this. I mean, this gentleman is already an interesting patient. He had COVID-19, had some issues. He may have had some lung issues initially, but really his main manifestation is cardiac disease, and he's profoundly sick initially. He's, I mean, by so many measures, the guy's in cardiogenic shock. And so when you see a patient who's in cardiogenic shock, you want to, I use this algorithm that was published in Circulation in 2017 by Van Diepen. And, you want to initially stabilize the patient with inotropes, vasopressors. If they're in respiratory failure due to cardiogenic pulmonary edema, you might need mechanical ventilation. And then if there's something specific, for example, if the patient has new myocardial infarction, you want to reperfuse immediately afterwards. And you kind of go on an algorithm either to the left or to the right of this slide here. Sometimes patients get better and they recover and they get out of that cardiogenic pathway. And other patients who maybe have multi-organ system failure or other issues, they go on the palliative pathway. But if they don't, and if they remain in shock, you want to quickly think about a mechanical circulatory support devices. And there's 4 different types. At least in the United States, mainly either inner balloon pumps, peripheral ventricular assist devices like Impella or tandem hearts, or in this case, what we're talking about is ECMO. And then those devices, those are the reason why you place them is for a number of different pathways. So the first one is a bridge to recovery. And so for many patients with myocarditis, and probably the case for ECMO, for COVID-19 patients, it's more serves as a bridge to recovery. So you put in the temporary mechanical circulatory support devices, they stabilize, they stay on it for a few days, and then they go on their merry way when their cardiogenic shock improves. The second thing is the bridge to definitive therapy. So this is for, you put a device in just to stabilize the patient until you come up with a definitive surgery or some kind of procedure to help the patient. The third thing, and this is rather common in the CCU world, in the cardiac intensive care unit world, is a bridge to decision. Basically, you put in this device until you figure out what to do with the patient. Anuj is smiling. He knows it happens, right? So, but basically, you buy a few days, then you have a meeting with different specialists, and then you decide on what to do with the patient next. The next one is these are for patients with end-stage heart failure, or maybe in this patient himself, is that it's a temporary procedure. And it's basically bridging you to a permanent ventricular assist device, like an LVAD or a transplant. What you really don't want is to have a bridge to nowhere. You need to think about an exit strategy before you place in one of these devices. And that's just because it increases morbidity. It drags out more of a poor quality of life before the patient passes away. And then the second thing is, at least in this patient, the decision is easy for me if I'm seeing the patient. I know that this patient in general has single organ failure, so I wouldn't want to think about the palliative pathway. He's on the younger side. And then his primary problem is his heart, and he has biventricular failure here. So I would quickly think about balloon pumps, but I don't think that would be enough peripheral support. And so you could either think about a peripheral ventricular assist device that is temporary, like an Impella device, but again, that's probably not the thing that's going to help both ventricles. And so I personally would reach and think about ECMO. So I'll defer to Karan here to talk about these two indices to help define cardiac shock. You want to talk more about that?
Yeah, so it wasn't something that I really utilized in residency, but coming to the University of Maryland, working through the cath lab with Dr. Gupta and one of his colleagues, Dr. Shalal, and also with our surgeons, there are multiple ways that we have defined cardiogenic shock. And I think there's been a large push, especially with Dr. Kapoor out of Tufts and the Sky, our group, our interventionalist colleagues, are really narrowing the definition, or at least defining cardiogenic shock uniformly. And I'll talk about cardiac power output and PAPI, or pulmonary artery pulsatility index, both of which have been shown to be very, very strong predictors of patients that will need mechanical support. The cardiac power output, I put the equation there, is the MAP times the cardiac output divided by 451, a constant they determine. And the PAPI is essentially a measure of how well the RV is functioning in terms of handling a preload and essentially demonstrating pulsatility. And both of these predictors, as I mentioned, both of these have been very strong predictors of needing a mechanical support. And the National Cardiogenic Shock Registry, a cardiac power output less than 0.6 and a lactate greater than 4 was a strong predictor of someone that would eventually succumb to the disease, 70% mortality. And so I was trying to define these patients before then. And I'll just make a plug, and then I think it's important when we factor in managing cardiogenic shocks, but especially patients that may have COVID myocarditis with the potential for recovery, is that you need a PA catheter. And I think a lot of our data that says that we don't need it comes from the ESCAPE trial, which some of you may be familiar with, but it is not a trial that guides these patients. Those were patients that were chronically ill, heart failure patients where there was equipoise whether you could actually manage these patients without a PA catheter. If you were on milrinone, you were excluded from the trial. If you were on dobutamine more than 3, you were excluded from the trial. So just a plug that I think that these kind of patients certainly need a PA catheter. And that brings in, again, to something Anuj talked about, whether it happens at the cath lab or at the bedside. And I'll give it back to Sammy of what he utilizes, and which I also utilizes, including the Sky system.
So I just put it in the chat box that I absolutely agree on the importance of a pulmonary artery catheter in this patient. He's any super sick patient with cardiogenic shock who you cannot rapidly stabilize with a inotrope or a short course of vasopressors really needs one. It really helps with managing the patient in the CICU setting. So there's this new classification for cardiogenic shock that was it's a joint guideline from the interventionalist community and the acute care cardiology societies, classifying cardiogenic shock. And so stage A is when you're at risk for shock. B is beginning shock. So in other words, a little bit of hypotension, tachycardia. Stage C is the classic shock, where you have hypoperfusion, but you could be stabilized and you're not deteriorating further. In this case, for this patient, he's at least stage D shock, so deteriorating shock, and he has hyperperfusion and he keeps on deteriorating, but it's not refractory yet, at least not yet. In stage E, basically the patient is basically being close to coding. So he's either D or E, and he's a super high risk for dying, as Karan was saying. And those kind of patients, you want to think about mechanical circulatory support devices early. And the reason why is because multiple cohort studies have shown that if you place a temporary mechanical circulatory support device after 90 minutes, you're much more likely to die than if you place it before 90 minutes. In this case, when you're thinking about the options, we already agreed that VA ECMO is probably the best choice. And so you have a few different access points here. Here's an illustration from Jack in 2014. This is obviously not your average patient that goes on ECMO. And there's two approaches. One is you go in through the femoral artery. Here, let me see if I can annotate this. I cannot. So you could go through into the femoral artery and the common femoral vein. And what it does is it sucks blood from the common femoral vein. It's actually a little bit higher up. It's near the IVC. And it sucks blood from there, dumps it through an oxygenator and a circulator, and then dumps it back in the femoral artery. And that blood gets pushed retrograde up into the great arteries and into the right arm and into the coronary arteries. So what you're getting with this is a retrograde oxygenation of retrograde blood flow, basically, to most parts of the body. The other approach is to do a central approach, and this I have seen it both at actually, our discussants are from University of Maryland, Hopkins, and both institutions, they've done this before, and the advantage of that is it allows patients to be able to walk and get physical therapy while they're on ECMO. It's a little less common than patients on VV ECMO. And then the third approach is to do an axillary approach, which is basically a surgical approach of doing this. And in the cardiac population, doing VA ECMO is kind of an incredible thing. These are super sick patients, but just by placing on this device, most of them do not end up being intubated. Most of them do not need an additional respiratory support because it's all done through the oxygenator through the VA ECMO circuit. So in the cardiogenic shock world, the reasons why you'd want to think about ECMO is using it in patients who have refractory heart failure or shock from acute coronary syndrome, post-cardiotomy, myocarditis, similar to this patient. After heart transplantation, patients with refractory ventricular arrhythmia is a little less common for that. And there's a little bit more evidence to use it in patients with sepsis-induced cardiomyopathy or hyperthermia. But I want to keep in mind that none of this has been studied, none of this has been shown in randomized trials. It's all based on just expert consensus in cohort studies. So I mentioned before that with VA ECMO, you get retrograde blood flow. You get blood flow from the femoral artery all the way up the great arteries, up the aorta, all the way up to the coronary arteries. And that makes it very tricky. So what you're doing is you're sucking blood from the venous circulation. So you're decreasing right ventricular and right atrial preload. And indirectly, you're decreasing left atrial preload. But because you're pushing blood back up through the aorta, you're actually not necessarily decreasing afterload. So here's the circuit here. This is a better diagram of that, where you see that blood's basically dumped in after going through the oxygenator into the aorta. And so this is inherently, like how well it works is inherently dependent on how well the heart works. And that's because blood, there's still some blood goes through the native cardiac circulation into the RA, RV, LA, and LV. And so it's a tricky balance. If you have if you turn up a lot of ECMO support, let's say you're going to 5 liters per minute, 6 liters per minute, you might be pushing blood back through all the way into the left ventricle, and so you have a much increased afterload, and that leads to increased pressures and volumes in left atria and more pulmonary edema. And so those patients will blossom on their chest X-ray, and they will go, they'll actually develop, more increased oxygenation requirements or increased amount of oxygen support on the ECMO circuit. And so that's why these patients need a PA catheter, because you could directly measure pressures in the left atria and in the pulmonary artery. The opposite also can happen. Let's say that the cardiac function is better than predicted, or maybe the patient's recovering on day 3 or day 4 of ECMO. And so what you see in those patients is that blood that does not go through the ECMO circuit increases. And if there's issues with lung damage, you may be having increase of deoxygenated blood being pumped by the heart. And that's a problem, because you don't want deoxygenated blood going into the coronary arteries or into the brain. It's called the Harlequin syndrome, where the top half of the body gets deoxygenated blood and the bottom half of the body gets oxygenated blood. And that's why every single patient who's on ECMO has some way of monitoring oxygen levels through the right radial artery. Because of these issues, and because many patients who are on full support for ECMO, they have increase in afterload and increased worsening cardiac output and more pulmonary edema, there's been an increase of popularity of doing left ventricular venting. And so, the first time I've heard the word LV venting, I didn't really understand what that means. What basically you're doing is you're trying to unload the left ventricle in different ways. And there's multiple ways of doing that. The first way is by decreasing LV preload. So you could try diuretics or other vasodilators to decrease the preload to the left ventricle, but that doesn't seem to work on patients who are in fluoride cardiogenic shock, but you can. The second way is to decrease to increase LV contractility through use of inotropes. And I've had patients on ECMO who are on inotropes or even vasopressors. But again, in patients who are on 5 liters, 6 liters of ECMO support, the effect that you gain, the amount that you kick the heart, is not much with these medications. The last way, and this tends to be the more popular way, is LV afterload reducing agents. So you could try using nitroprusside or other agents, but much more popular is to use a different device to decrease LV afterload, and this is what LV venting is. It's basically using another mechanical circulatory support device to suck blood, or to make it easier for the heart to pump blood into the aorta. The most evidence probably is for patients who have interaortic balloon pumps. These are studied in about 800 patients or so. And it showed a reduction, again, this is not randomized controlled trials, but this is in cohort studies, where it showed a reduction in mortality if you simultaneously put a balloon pump in a patient with an ECMO circuit. There's also evidence for using Impella support. And so what Impella is, and Anuj could discuss this probably better than I can, but it's basically a turbine on a stick. It sucks blood from the left ventricle and it dumps it in the aorta. So it indirectly, it definitely helps unload the left ventricle. It doesn't really change afterload all that much, but it calls for a heck of a lot of support for the heart. And the new fancy, excuse me, Impella devices could suck up to 3.7 liters through a percutaneous route. You can even put a surgical one that could do 5 liters of cardiac support. So between an ECMO circuit and an Impella, you could offer up to 10 liters of cardiac output per minute, which is incredible. So in this patient, I would think about, I would put a VA ECMO circuit in, and then within an hour, I would take a look at their right heart cath numbers. Is their wedge going to be higher? Are their lung findings worse? If so, I would definitely consider either a balloon pump or an Impella. I probably would favor an Impella device just because it could offer more support, and I would do it very quickly. There is a recent review article discussing how many patients get LV venting in patients on ECMO, and it's about 16 to 20% of patients. So it's becoming much more popular to use 2 devices to support these patients.
A couple of things that I'd like to point out. One is that this approach requires a close relationship between your cardiologist and your cardiac surgeons. You've got to work well together as a team in order to make this work. I can put a patient on VA ECMO, and I can put an Impella in. These inserting the devices is not the issue. Managing these patients with a perfusionist and making sure you're taking care of these patients and looking for these things like Harlequin syndrome are incredibly important. That's number one. Number two is, I think we have to recognize that these devices are incredibly expensive. I don't know if everyone's familiar with this, but an Impella device can cost anywhere from $25,000 to $40,000, depending on the support level of support we need or choose. And on top of ECMO, which is not very expensive, it's just very large tubes with an oxygenator, but the daily management of that patient with a perfusionist managing that circuit, this kind of support can get very expensive very fast. And so at least at University of Maryland, we've had very close working relationships with our cardiac surgeons, and we've made sure that everyone's on board before we start going down this road of saying, okay, this is a young patient, we're gonna put them on VA ECMO, and then if they need venting, we're gonna put the Impella in, or we're gonna do a septostomy. And oftentimes you figure out you need a septostomy at 2 in the morning. It's like a STEMI for these VA ECMO patients. And so, you know, we've gotten very close working relationships with our surgeons in order to make this work.
Yeah, I didn't discuss septostomy. That's what that is basically you're creating a hole between the left and right atria. And so you don't care as much if the LV afterload increases, because a lot of that blood, the oxygenated blood, will get shunted to the right side of the heart. And so basically it's a way of unloading the left ventricle. And the other thing that Anuj alluded to was frequent use of echoes. These patients should be getting an echo at least once a day, if not 2 times a day, just to make sure that you can see how well the aortic valve opens, because that's a way of telling how much blood the heart is ejecting. If you offer full support, or if the heart's super weak, the aortic valve may not open at all.
And I've seen LVs completely fill up with thrombus because that wasn't recognized. So it's a very scary event. So I think these patients get very carefully monitored.
I think the last point that Anuj, actually the biggest point that Anuj was making was the fact about a close working relationship. This cannot happen without either a formal or informal cardiogenic shock team consisting of a critical care physician, a cardiologist, interventional cardiologist, heart surgeon, cardiac anesthesiologist, and a perfusionist.
Before I cover some of the last parts of this, and I only need 5-ish minutes. I don't know if Dr. Shah or anyone had any questions for Dr. Zakaria or Dr. Gupta here. Okay. All right. So we'll move on to the to this last part, and I don't have the titles like my colleagues here. And nor the expertise like them, but I will try to cover as much as I've been learning along with all of you in terms of long-term implications for the heart, specifically from a standpoint of myocarditis. So when we talk about myocarditis, generally if a patient comes in with myocarditis and they have fulminant myocarditis, if they survive that episode, there's actually a 93% chance of survival. They've done case series and case reports going through this, and there was a 10-year case report that if a patient got through that fulminant myocarditis, that cardiogenic shock, acutely ill, lactates like this patient in the 9, they have very, very good survival rates. It's the patients with subacute myocarditis that tend to have lower survival in the same studies that have been gone before. So what implications does that have going forward? So late in July, in JAMA, there were several studies that came out specifically regarding cardiac MR and whether patients had evidence on the cardiac MR of involvement in the myocardium. These were studies that actually the Big Ten utilized, professional sports like Major League Baseball, along with schools, to help define whether they were going to continue their seasons, open schools, and so forth. Because in these studies, they indicated that 70% of patients, regardless of whether they had comorbidities to begin with or not, had myocardial involvement by MRI in their patients. And so I just want to briefly touch on these because it helps kind of define what these long-term effects are going to be. We had prominent cardiologists providing editorials, including Clyde Yancey at Northwestern and Greg Fonarow at UCLA, whether we were entering a new era of heart failure, a new era of phenotype. Just as the study was published, though, the same study also indicated that there were several errors in their statistical measures and how these numbers were calculated. So I want to briefly go through that. So this is from the study, a cardiac MR study. And basically what you can see here in this two-chamber view is the short axis view is the native T1 and T2 signals. Now, I'm no cardiac MRI expert, and talking to some cardiac MRI experts on how do we define this. T1 mapping and T2 mapping are generally an idea of trying to look for inflammation, and especially T2 looking for edema. So if we're thinking about COVID myocarditis, this would presumably be a pattern that would help us identify whether patients had involvement. And of course, late gadolinium enhancement, which tends to be more of a marker that corresponds clinically for patients. So just looking at the chart here, if we notice, we have COVID-19 patients, they had 100 of them, healthy controls, and then we also have risk factor adjusted controls. And if we notice in the population of patients, regardless of controlling for risk factors, you see that there is a discrepancy in the patients, whether they had hypertension, diabetes, hyperlipidemia, BMI. So whether they had COVID or not, there was a discrepancy in the risk factors that they begin with. And then going specific to the study. So they defined the study as saying that in one patient population, the COVID patients, they had on MRI an LVEF of 57%. In the risk match control, 62%. Whether that has any clinical significance, I don't know if Dr. Zakaria or Dr. Gupta would agree. It just seems like there's minimal indication of whether that actually has any change in the clinical index. But this is where there was a large concern that was brought up, whether a lot of these patients long-term were going to have myocardial injury. They said there was a significant difference in the T2 signals and the T1 signals. And these values are defined by individual MRI laboratories. And if we notice, generally, there is a small difference between one and the other. And there hasn't been any data to say whether this is a clinically significant difference. Now, what was demonstrated was that there was about 30% of patients that did have a late gadolinium enhancement, which we know is associated clinically with myocardial injury compared to the risk factor, risk match control patients. But these were not in the typical patterns that we see for myocarditis. And if we notice in terms of other blood markers, while there was a significant difference in the high sensitivity troponin, it wasn't elevated in terms of the absolute values, along with the NT-proBNP. So how do we interpret all this? And I think it's similarly for many of the pulmonary critical care colleagues is, well, what is going to be the long-term effect of COVID? Is it going to be some type of restrictive pattern on patients breathing? Same thing is in terms of, from a cardiology perspective, is this going to be defining a new type of heart failure phenotype? Is this going to be a HFpEF phenotype? Are these patients going to be a dilated cardiomyopathy phenotype? Are these patients that are post-COVID, do we have to get MRIs on everybody to essentially define whether they're going to have cardiac involvement? And I think the study essentially ignited a fear that that may be something we have to do, but if you look more closely at it, whether it actually has any clinical significance and whether that's going to be the case is not clear. And so guidance for me for this patient that had demonstrated COVID myocarditis with significant cardiogenic shock and elevated troponin and markers in terms of his cardiogenic shock in the hospital, this would be someone that would potentially obtain an MRI to continue to look for resolution, looking to see if there's long-term late gadolinium enhancement indicating scarring. But not every patient that leaves the hospital Not every patient that has troponin would that be the case, and I still think that's not to be defined. But as cardiologists, as pulmonologists, as critical care doctors, I think we still have a long way to go and a lot of learning to do in terms of defining whether we're going to be having a population of patients that are COVID heart failure patients long-term, and whether that's the traditional therapies that we've utilized in heart failure and newer therapies, including like SGLT1 inhibitors that have demonstrated a large benefit in patients, whether they're going to have any benefit in these patients.
Nirav, do you know if there's been any post-recovery pulmonary function testing studies on COVID patients?
So there are a lot of post-ICU, post-COVID clinics that are starting to recruit patients, and that's where a lot of these studies will be done: 6-minute walk tests, PFTs, and so I think we'll see more data there. In fact, one of the sessions coming up in a few weeks for this is post-ICU, post-COVID clinics, and kind of how they're being set up and what they're looking at. But I think that that's going to be a really important point to talk about, kind of what are we dealing with in terms of lung function? Because Karan's absolutely right that we're not sure what we're going to see. We think it's going to be a restrictive ventilatory defect, but at the same time, the interesting part's going to be what's the diffusion capacity, and is the diffusion capacity markedly reduced compared to the PFT abnormalities in the spirometry and the lung volume?
It'll be interesting to see also the correlations between what the chronic heart disease patterns will look like and the chronic lung disease patterns will look like. Absolutely.
And Karan, you touched on this a little bit, but there was talk about elite athletes and kind of the idea of whether they should be getting MRIs when they recover from COVID because of the high impact of their kind of their job, if you will, and whether they're at harm. Any thoughts about that?
I think a lot of that started with the Boston Red Sox pitcher who was now out for the year, and I would ask myself if it wasn't COVID and it was a myocarditis patient and it was a young athlete and they were returning after recovery from myocarditis, and I had given them some type of anti-inflammatory, steroids, IVIG, and this was maybe a college basketball player. I would say maybe the evidence doesn't tell me that I should get an MRI on the patient, but my clinical feeling and my gestalt says that this patient, I want to be more positive. I want to make myself feel better. I want to make the patient feel better, reassure that we're not missing residual disease here and that it hasn't gone completely untreated, and also to define the heart failure therapy that he would or she would be on going forward. So I would say maybe the evidence doesn't say it, but I would obtain an MRI.
I agree 100%.
Great. Well, we definitely have time for some questions. If you guys want to type them into the chat box or kind of ask our panelists here questions about this. I think that the initial focus of a lot of COVID care was the lungs, and kind of these patients with their hypoxia. But we quickly realized that this was not just a single organ issue, and that this was definitely affecting the entire body and the heart. While it is second to the lung in importance, that it equally had some issues going on with it. And so I can only say that on this panel with my friends who are cardiologists, but I think that it's important to remember that there could be some long-term implications here, and we should probably, Dr. Gupta mentioned the partnership between cardiac surgeons and cardiologists, but I would say that probably in terms of care of these patients after they leave the hospital, it's going to need to be a multidisciplinary approach to taking care of them.
And just to that, quickly to that point, Nirav, is while there's been a lot of devastation with COVID in our, with our patients throughout the hospitals, the clinics, and so forth, one of the things that has been very encouraging is the collaboration across fields and disciplines. It was great to be invited to talk with the pulmonary critical care doctors here with 3 cardiologists, and so I think if anything comes forward, especially for those early in career, is building these relationships early with other disciplines as we take care of patients. Because I think multidisciplinary clinics and multidisciplinary units are the ones that are best going to take care of these patients and not those in isolation.
Absolutely. There's a question in the chat box. Oh, go ahead, Anuj.
No, I was going to say one of the questions on the chat box was this question of fibrosis versus viral inclusions. I think that question is still unanswered. I think it's unclear what's happening in the heart, in the myocardium, when patients develop complications related to the heart during their infection. Again, we have this case where they found on the H&E stain evidence of viral inclusions and inflammatory cells. We have other case reports that suggested that there are no inflammatory cells and just microthrombi. And so I think there may be variable effects on the myocardium in this context. And I don't know that we know the answer to that question yet. I think it's a great question. I don't know that we're anywhere close to answering it.
And just to that question, so at the same time that the MRI JAMA study was published, there was a 39 series patients autopsy study published, which I didn't talk about here, but in 24 out of 39 of those patients out of this study, they did demonstrate that there was some form of virion in the myocardium, whether it was in the macrophages itself or actually in the myocyte. So whether the inflammation, prolonged hypoxemia is what's leading to myocardial fibrosis versus actually some kind of direct toxic effect of the COVID virion is unclear.
How about with arrhythmias? Have there been any patterns acutely, subacute or chronic patterns for arrhythmias in these patients?
So I think a lot of the initial data that came out was hard to separate away from the hydroxychloroquine that was used widely across many institutions. And so we know the hydroxychloroquine has a pattern to leading to QT prolongation and ventricular arrhythmias. Though Dr. Zakaria or Dr. Gupta, I don't know in your experience, but I've definitely seen personally, anecdotally, and in some of the case reports, a lot more atrial arrhythmia, which makes sense in the setting of patients that are hypoxic with atrial stretch and injury around the atria.
I've seen both, and I think it's just, whenever you have myocarditis, it just causes, you have inflammation of basically the entire heart, and so you'll have atrial and ventricular arrhythmias.
I'm not saying that there's no inflammation in the heart. I'm saying that we've seen different patterns of damage to the myocardium, both ones where we found viral inclusions and evidence of inflammation in the myocardium and damaged hearts, and we've seen patterns where there's no evidence of inflammatory cells and no viral inclusions and just microthrombi. And the answer is not that corticosteroids don't play a role. It's just that I think it's still incredibly confusing. And unfortunately, that's where I would leave it.
I agree with that.
There was a question that came across privately, but it was any comments on ACE and other causes of injury that could be blocked, potentially avoiding some of the cardiac injury?
So just today at the European Society of Congress, the first randomized trial of holding ACEs and ARBs versus continuing them in patients with COVID-19, it was called, as cardiologists tend to do, come up with quirky trial names. It was called Brace Corona, and it was published today, and the results were released, and there was no difference in 30-day mortality, clinical markers of clinical outcomes, including days on a ventilator, hypoxia, with holding ACE or ARBs between those therapies. So whether blocking ACE or ARB, blocking the ACE will change whether someone develops cardiac injury or respiratory illness specifically, I don't know the answer to it, but at least to the question of ACEs and ARBs being held, I think we've put that one to rest. For patients, at least that come to the hospital that are on these therapies that are not in a shock state, I think it is appropriate to continue them.
Great. I think we have time for one or two more questions here. Any effect on the statins long-term for patients recovered from COVID-19?
Maybe I'll take the question as well. So at MGH, I believe, their protocol was actually to start statins if they hadn't been on them in patients with COVID-19. I don't know if it's still part of their protocol or not. And some of that comes from, I believe, some of the ARDS data that statins may have a pleiotropic anti-inflammatory effect. And these patients may benefit from being continued on them. We know that there's an anti-inflammatory effect in acutely stabilizing or helping stabilize in acute coronary syndrome. So whether that extends out to COVID-19 is unclear. But in terms of whether the long-term effect, I don't know. I mean, I think part of that is still trying to figure out what does COVID-19 do to the microvasculature long-term. Does it trigger a persistent oxidative stress pathway that's going to eventually lead to increased coronary plaque and disease? So generally, I would think these patients should continue on statins if they've been on them. Whether they should be restarted on them, maybe there'll being a role for coronary CTA or coronary calcium score in patients post COVID-19 illness to help decide a statin therapy.
Great. Well, I wanted to thank all of our speakers today, Dr. Karan Desai, for putting together this presentation and kind of spearheading the discussion today, Dr. Anuj Gupta, and his insight from the cardiac cath lab and for the general case in general, and Dr. Sammy Zakaria from mechanical cardiac support. I think it was an insightful presentation and discussion. Thank you for your questions. Please make sure you go to the feedback link to give us some feedback and tell us topics that you'd like to hear about in the future. And tune in next week for obstetrics and COVID-19, which I'll tell you as a critical care doc in this time, obstetrics scares us in the ICU in general, but especially in COVID-19 patients. So stay tuned next week for that topic. Thank you all and have a great night.
Thank you, Nirav. Thank you, Karan.
Thanks. Thank you, guys.